everyone, and welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Hanin, your host for today, and with me is Malak, who will be enlightening us on a part hydration station, part cleaning crew, aka salivary glands.
Hello, I'm delighted to be here.
Is it true that salivary glands produce around a liter of fluid?
Yes, you're right, but there's so much more to them. In this episode, we will be discussing salivary gland diseases, from things like infections and autoimmune conditions to benign and malignant tumors.
Alright, let's dive right in. Before we start, why don't we quickly review the main salivary glands and the types of diseases that could arise in them?
Of course, we've got three major pairs of salivary glands: the parotid, the submandibular, and the sublingual glands. Each one has its own set of quirks when it comes to pathology.
Interesting. And if I remember correctly, the parotid glands are the largest of the bunch?
Yep, you're right. Besides the big size, the parotid is the most commonly affected when it comes to tumors. We find majority of pleomorphic adenomas and mucoepidermoid carcinomas here. Besides neoplasm, it is a classic site for viral infections like mumps, especially in kids.
Got it. So think tumors and viral infections for parotid. And the submandibular gland?
This one sits underneath the jaw and is a common spot for salivary stones, which is also called sialolithiasis. This can lead to obstructive sialadenitis and inflammation in the gland due to blockage, especially bacterial infections like Staph aureus or Strep viridans.
Some new terms to tackle here. Remember, for sialolithiasis, lith also means stone, and for obstructive sialadenitis, itis refers to inflammation. Would we find any tumors?
They can happen here too, but they're less common than in the parotid.
Alright, and finally, what about the sublingual gland?
Small but mighty, they're the least common site for tumors, but if they get tumors, they're more likely to be malignant, about 70 to 90% of the time.
That's a helpful rule of thumb. The smaller the gland, the higher the chances of malignancy.
Yep, you got it. Also, keep in mind that there are some minor salivary glands that are spread all around the mouth and the oropharynx. They can also develop tumors or mucoceles, especially after trauma like lip biting.
Alright, a quick recap. Parotid glands, think of tumors and mumps. When it comes to submandibular, it is more likely to be obstruction and infection, whereas sublingual, rare, but keep an eye out for a cancer.
I think we're ready to tackle a case now. We have a 40-year-old woman who presents with a mass of 2 years duration, located just in front of her left ear. On examination, it's painless, mobile, and well circumscribed.
That's quite a long time to have a mass without any pain, and it's unilateral, well circumscribed, and in the parotid. Sounds like some kind of tumor. Could you guide us through this one, Malak?
Of course, Hanin. Considering the location and features, like you said, I'd be thinking of the most common benign salivary gland tumor, which is a pleomorphic adenoma. But before we talk about tumors, let's first review some other key salivary gland diseases. Starting off with something very common, a mucocele. These are fluid-filled swellings that happen when a salivary duct gets blocked or ruptures, usually after trauma like lip biting.
People tend to bite their lower lips, so would that be where these mucocele are found?
You're right. You will notice a swelling that varies and is sometimes bluish. It might even grow with meals.
What about inflammation of the salivary glands?
If inflammation hits the glands, that's what we call sialadenitis, and it can have many causes. It can be acute or chronic, and if it's acute, it can be viral or bacterial.
But Malak, how can we differentiate between the different causes?
Let's look at them one at a time. Viral sialadenitis, like mumps, causes swelling of both the parotid glands, aka bilateral diffuse swelling. It is more commonly seen in kids, and it may come with fever and malaise. Acute bacterial sialadenitis is usually unilateral and painful. Not only that, but it can have pus draining from the duct. This condition can be triggered by dehydration or obstruction, like sialolithiasis, or basically stones in the salivary duct. And let's not leave out the bugs. The most commonly responsible pathogens are Staph aureus and Streptococcus viridans.
That definitely makes it clearer. We've covered the acute infections. What about chronic inflammation?
We call it chronic sialadenitis. This is more subtle. It may be less painful than acute and persistent, and often happens due to repeated infections or autoimmune diseases.
From blocked ducts to full-on inflammation, we've got a lot happening in these little glands.
Agreed. And just when you think it can get messier, the immune system shows up and makes it personal. We've got a name for it too, Sjögren syndrome.
Oh, yeah. Isn't it that condition that people always forget about unless they hear dry eyes and dry mouth together?
Yep, that's the one. Sjögren syndrome is an autoimmune disorder targeting the exocrine glands, especially the salivary and lacrimal ones. That leads to three things: xerostomia, keratoconjunctivitis sicca, and enlarged salivary and lacrimal glands.
I heard some big words in there.
Okay, let's go through each one. Xerostomia means a dry mouth because of the decreased production of saliva that can lead to many problems, like fissuring and ulceration, difficulty in swallowing and speaking, dental caries, and candidiasis. On the other hand, keratoconjunctivitis sicca is a long way to say dry eyes.
Correct me if I'm wrong, Malak, but isn't Sjögren syndrome common in middle-aged women?
You're absolutely right. It can be primary, aka the main disease the patient has, or it can be secondary to diseases like rheumatoid arthritis or SLE.
And what should we look for to confirm a diagnosis of Sjögren syndrome?
First and foremost, a blood test, which would show positive for anti-SSA Rho and anti-SSB LA antibodies. We can also obtain a lip biopsy to confirm it with the presence of lymphocytic infiltration. There is one major concern though. These patients tend to have a 40-fold increased risk of B-cell lymphoma.
Okay, I'm gonna be honest. I can't stop thinking about our patient with the 2-year-long painless mass in front of the ear. You said that it might be pleomorphic adenoma?
Yeah, let's discuss it then, shall we? Pleomorphic adenoma is the most common benign tumor of the parotid gland, made up of epithelial and myoepithelial cells in a chondroid matrix background.
So, it has some different types of tissues in there, like the epithelial and myoepithelial cells in a chondroid matrix. That's why it's pleomorphic?
Yep,
And a chondroid matrix background refers to a cartilage-like histological appearance.
you're right. These tumors are well circumscribed, slow growing, and usually don't hurt.
I've heard that they can act out too.
Absolutely. Even though they look harmless, they can be pretty sneaky. Pleomorphic adenomas have microscopic extensions through the capsule, which means that they can come back if not removed properly.
Can't we just remove the tumor along with some more surrounding tissue?
Yeah, that's pretty much what we do. The key is doing a wide margin resection to make sure that none of those little pesky extensions get left behind.
Is it really that important to make sure that none of it remains?
They could undergo malignant transformation, especially if you start seeing signs like facial nerve palsy.
So, that was the most common benign tumor. Now, what about a tumor that starts off malignant? What's the most common one we should be worried about?
That would be mucoepidermoid carcinoma. It is the most common malignant salivary gland tumor, and it often involves the facial nerve.
That kind of sounds like what we just discussed, with the pleomorphic adenoma turning malignant. So, how can we tell them apart?
Through histology, mucoepidermoid carcinoma contains a mixture of mucus-secreting cells, aka muco, squamous cells, aka epidermoid, so mucoepidermoid. It also has intermediate cells. All that sets it apart from the pleomorphic adenomas.
And let me guess, like all tumors, the prognosis depends on the grade?
Exactly. Low-grade tumors have a 90% 5-year survival, which is good, but unfortunately that drops to 40 to 50% for high-grade tumors.
Alright, so after walking through all those salivary gland diseases, I've got to say you were right, Malak. Our patient most likely had a pleomorphic adenoma because of its location and the fact that it's chronic, painless, and well circumscribed. Quick reminder for everyone to fire up their neurons. We're approaching our practice questions. While that happens, can we briefly go over how to approach salivary gland swellings?
You got it. Here's a quick way to think about it. Start by asking whether the swelling is acute or chronic. If your answer is acute, the next question would be regarding the timing. Does it manifest with eating? If yes, think about obstruction.
Like sialolithiasis or salivary stasis?
Yes, exactly. However, if the swelling is acute but constantly present, even when you're not eating, we will look more into their features.
I don't remember them quite well, Malak.
No worries, let's go over them again. When it is painful, red, and unilateral, it is a classic presentation of acute bacterial sialadenitis, especially if you see pus coming out of the ducts. And this usually happens due to Staph aureus or Strep viridans. On the other hand, when it is painful, diffuse, and bilateral, think viral sialadenitis, like mumps.
Thanks for clearing that up, Malak. Now, what if the swelling's been there for a while?
This will now be called chronic, and we divide them based on whether it's bilateral or unilateral.
Oh, I know. If it's bilateral, then we think of autoimmune causes like Sjögren syndrome.
Well, Hanin, you've been on your A game today. So, if bilateral, think autoimmune. Now, in the case of unilateral swelling, we need to check whether it's diffuse or circumscribed. Diffuse unilateral swelling points to chronic sialadenitis, like from repeated infections or duct damage. But circumscribed unilateral swelling, that raises red flags for a tumor, especially if it's painless and persistent.
That's such a clear breakdown. First, classify them as acute or chronic, and then just follow the pattern from there on.
Exactly. It's like a flowchart that you can follow in your head.
Alright, everyone, let's bring out our stethoscopes for today's practice questions. Well, mentally at least, a 45-year-old man presents with a painful erythematosus swelling on the right side of his jaw. He reports that it's always swollen but worsens with meals, and that he has been feeling dehydrated lately. On examination, purulent discharge is noted from the salivary duct opening. Which of the following organisms is most likely responsible for his condition? A. Epstein-Barr virus. B. Mumps virus. C. Staphylococcus aureus. D. Candida albicans. E. Streptococcus pneumoniae.
The answer is C. Staph aureus. This patient has features of acute suppurative sialadenitis, painful unilateral swelling, which is constant but becomes worse with eating, and there's pus from the duct. It's often triggered by dehydration or obstruction, and commonly caused by Staph aureus or Streptococcus viridans.
Okay, let's do one more. A 52-year-old woman presents with chronic bilateral swelling of the parotid glands, along with complaints of dry mouth and gritty eyes. She has a history of rheumatoid arthritis. A lip biopsy reveals lymphocytic infiltration of salivary glands. Which of the following laboratory findings is most likely to support the diagnosis? A. Anti-centromere antibodies. B. Anti-SSA Rho antibodies. C. Anti-double-stranded DNA antibodies. D. Anti-topoisomerase 1 SCL70 antibodies. E. Elevated ASO titer.
The correct answer is option B, anti-SSA Rho antibodies. This is classic Sjögren syndrome, which often presents with xerostomia, keratoconjunctivitis sicca, and bilateral gland enlargements. Anti-SSA and anti-SSB antibodies are the key serological markers.
And with that, we will wrap up today's episode on salivary gland diseases. It really was the full spectrum, from blocked ducts and bacterial infections to autoimmune syndromes and tricky tumors. Hopefully, it's now easier to approach a case of salivary gland swelling with a structured mindset.
Totally. And just remember, acute versus chronic, unilateral versus bilateral, and always keep that risk of malignancy in mind, especially in smaller glands.
Thanks so much for walking us through all of that, Malak.
Of course. Thank you for having me, Hanin.
And to everyone listening, stay tuned for more high-yield cases and clinical breakdowns in our upcoming episodes. Until next time, stay curious.